So that is one of the reasons why we have to take an HRCT temporal bone before going for a mastoid or a middle ear surgery. Okay, because you have to minimize the risk of injury to facial nerve. Now, what are the other things that can help in minimizing the risk of injury to facial nerve? I already told you about some landmarks, didn't I? So, we have to look for these landmarks whenever you are performing a surgery. For middle ear and mastoid surgery, what are the landmarks to look for? First thing, it is the processus cochleariformis that you see here. Okay, and secondly, you have to look for the lateral semicircular canal. This is the lateral semicircular canal. Then you have to look for the area of short process of fingers. This is the area of short process of fingers. Then you have the oval window. Here you have the pyramid. Then you have the tympanomastoid suture line, and finally you have the digastric ridge. This is the area where the digastric muscle is getting attached, the posterior belly getting attached, and externally you have the digastric groove and internally you have the digastric ridge, and this digastric ridge forms a landmark for the facial nerve. Okay, and tympanomastoid suture line also forms a landmark for facial nerve. So there are 7 landmarks for middle ear and mastoid surgery, and for the parotid surgery you also have to look for the other landmarks such as groove between mastoid and bony AAC, which has been bisected by the facial nerve, and then you have the tragal pointer, or it is also known as Conley's pointer. Okay, this is what is called Conley's or cartilaginous pointer. Okay, this part of the pinna cartilage points towards the facial nerve, as you can see here, and styloid process is another landmark for that. Here you have the facial nerve and the posterior belly of digastric. It is getting attached to the digastric ridge, right? So this digastric muscle is also forming a landmark. So apart from the tympanomastoid suture line, which is being repeated here, you also have in the tympanomastoid suture line, it lies 6 to 8 millimeter deep to the suture. Okay, and groove between mastoid and bony AAC, tragal pointer, it is also known as Conley's pointer. Okay, Conley's pointer or cartilaginous pointer. Then styloid process, lateral to styloid process lies the facial nerve, antero-inferomedial to the tragal pointer lies the facial nerve, and superior and parallel to posterior belly of digastric lies the facial nerve. Okay, so these are the various landmarks that you have to know about the facial nerve. Okay, now coming to the histology of facial nerve. How does it appear? The facial nerve is actually having fascicles arranged together within a perineurium, and each of these fascicles are covered by perineurium. Sorry, what did I tell you? The fascicles are arranged together in an epineurium. Okay, there are a lot of fascicles within the epineurium, and each of these fascicles is being covered by a perineurium. Okay, here you have a perineurium. This is another perineurium, and within it you have got the fascicle, and like that many fascicles are together, bundled together within epineurium. Okay, and within the perineurium you have multiple nerve fibers, and these have endoneurium surrounding it. Endoneurium surrounds the neurilemma, myelin sheath as well as the axon. Okay, now why do we have to know this? Because only if you learn this you will be able to understand the classifications of nerve injury. It is not just for facial nerve, it is common for all nerves. There are 2 types of classification, that is the Seddon's classification as well as the Sunderland's classification. The Seddon's classification, it can be divided into 3 types: neuropraxia, axonotmesis, and neurotmesis. Okay, neuropraxia means there is a transient blockage of the exoplasmic flow. So there is complete reversal of the facial nerve function after that transient reversal is removed. Okay, whereas in axonotmesis there is a injury to the axon. Okay, axon is injured. So this will be kind of like Sutherland type 2, and in neurodemesis, here the nerve fibril is disrupted, the endoneurium is not intact, whereas in axonomesis the endoneurium is intact. Okay, so that is a big difference between neurodemesis and axonodemesis. And according to the Sutherland's classification, it can be divided into 5 types. Okay, and the 4th and 5th depends upon whether there is injury to epineurium. Here you have injury to perineurium. In 3rd degree you have injury to endoneurium. Okay, and secondary is same as axonodemesis. Primary same as neuropraxia. Okay, so this is how the Sutherland's classification is. Okay, so these are the classifications of nerve injury that you have to know. Now coming to the blood supply of the facial nerve. The CP angle area of the facial nerve, that is the intracranial part of the facial nerve, is being supplied by the ICA or the anterior inferior cerebellar artery, and the part of the internal auditory canal, that is the meatal segment, is being supplied by its branch, the labyrinthine artery. This labyrinthine artery also supplies the labyrinthine part of the facial nerve, and the perigeniculate area is being supplied by the superficial petrosal branch of middle meningeal artery, and here it is anastomosing with the stylomastoid branch of facial nerve, stylomastoid branch of posterior auricular artery, which is supplying the mastoid part. Okay, this is supplying the mastoid part, and this is anastomosing with the superficial petrosal branch of middle meningeal artery, that is supplying the perigeniculate area as well as the tympanic part. Okay, so an anastomosis is occurring here, and this is the blood supply of facial nerve. Now coming to the topodiagnostic test of facial nerve. What is this topodiagnostic test? What we are trying to do is we are trying to find the area where the facial nerve has been involved. Okay, how can we find this? We know the various branches of the facial nerve, right? So what we are trying to do is we are trying to see which all branches of the facial nerve are injured, and from that we are trying to see where the lesion is. Okay, so how is the facial nerve coming? First of all, we know it is coming from the intracranial part, and then it goes into the internal auditory meatus, forms the meatal segment, yes, and then it forms a labyrinthine segment, and then it takes a turn to form the geniculate ganglion, and then it forms the mastoid segment, and it comes out to the stylomastoid foramen, and it divides into 2 and further into 3. Okay, this is something which we know, right? Now what are the branches? We know that there are no branches in the area of CP angle or the meatal segment or the labyrinthine segment, but one thing is that in the area of CP angle it is associated with other nuclei. For example, the facial nerve is actually winding around the 6th nerve nuclei, right, the abducens nerve nuclei, and this is what is called the facial colliculus. So if these two are injured together, it can occur in a stroke when blood supply of that area is involved, and that is what is known as Millard-Gubler syndrome. Okay, Millard-Gubler syndrome. Here the patient will have an element facial palsy along with a 6th cranial nerve palsy. Like that we are able to understand that this is the area of insult. Okay, now how to differentiate between UMN and LMN facial palsy, I will be coming to it soon, but for now just understand, okay, how we are trying to analyze where the facial nerve is getting involved. Okay, now what else we have to look for? We have to look for the branches. This is the branch, the greater petrosal nerve. Here we have the nervus epidius coming from the vertical part of facial nerve, and we have the cauda tympani branch. Okay, so these are the branches So this is the greater petrosal nerve, this is the nerve to stapedius, and here you have the chorda tympani nerve. Okay, so these are the various branches of the facial nerve, and then from this how are you going to analyze? Okay, we know that greater petrosal nerve is a nerve which is responsible for lacrimation, right? This is for lacrimation, and we know a test to assess the integrity of the stapedius muscle or the nerve to stapedius. What is that? We can assess the stapedial reflex, right? Here we can assess the stapedial reflex or the acoustic reflex. And chorda tympani, what we can do? We can assess the taste sensation, right? Taste sensation. So how to assess the lacrimation? This lacrimation is being assessed by a test what is known as Schirmer's test. Okay, Schirmer's test is used for assessing lacrimation. Okay, now what we are doing is we are keeping a filter paper on the lower papillary fissure and comparing with the opposite side and looking for wetting of the filter paper. Okay, and with the difference in the wetting we can understand how it is positive or not. Okay, if the patient is not having wetting in that filter paper or very less wetting when compared to the other, that is indicative of an injury proximal to the area of the greater petrosal nerve. Okay, so that is how we assess for Schirmer's test. Then we assess the stapedial reflex, then taste by electrogestitometry, that is to assess the chorda tympani, and the salivary flow also for chorda tympani, salivary pH also for the same. Okay, chorda tympani nerve, and with that we can understand how if a patient is having a decreased lacrimation, that is on doing the Schirmer's test. Okay, and the patient has no other problem, it means the patient is having a lesion which is proximal to that. And if the patient is having no problem with this lacrimation and only the stapedius is involved, the taste is intact, that means, what does it mean? It means the lesion is somewhere around here, right, between the branch of greater petrosal nerve and between stapedius, right. And if the stapedial reflex is intact and the taste is gone, it will be somewhere here, right, the lesion. Like that we can assess where the lesion is. Okay, so that is why it is called as a topodiagnostic test of facial nerve. You will understand it further when you see this question. Sorry, yes, level of facial nerve with intact lacrimation on Schirmer's test and loss of taste in anterior two-thirds of tongue. Okay, here the lacrimation is intact on Schirmer's test and the taste is involved. So what does that mean? It means the chorda tympani nerve is involved. Okay, the taste is involved. It means the chorda tympani nerve is involved, but what is not involved? The Schirmer's test shows intact lacrimation. Okay, so if the Schirmer's test has to be positive, it has to be occurring somewhere proximal to it, that is somewhere over here. So that won't be the case here, and here the stapedial reflex is intact or not, we had to look for. Okay, it has not been mentioned, so it could be either in the area which is just distal to the greater petrosal nerve. So it could be anywhere in the tympanic segment or the mastoid segment up to the area where the chorda tympani branch is given. Okay, anywhere over there it could be. Now we can see the options: horizontal segment, labyrinthine segment, internal aortic canal, xylomastoid foramen. Now we know that it is not xylomastoid foramen because the branch is given about 5 mm before exiting the xylomastoid foramen. Okay, we know it is not in the meatal segment because the lesion is somewhere after the greater petrosal nerve. So that is not the answer. Now labyrinthine segment also for the same reason, that is not the answer because the nerve is given after the greater petrosal nerve has been given. Okay, now horizontal segment, or if the option had been mastoid segment, that also is the right answer. Okay, so this is the right answer. So this is how you analyze for the area where facial nerve has been involved. Now, how will you differentiate between a UMN falsi and a LMN falsi? Okay, UMN means upper motor neuron lesion, LMN means lower motor neuron lesion. I told you that the motor nucleus has got supply from both the hemispheres, right? The upper part has got supply from both the hemisphere and the lower part only from the contralateral hemisphere. And this motor nucleus is the LMN. Okay, from the motor nucleus and below forms the lower motor neuron, and up to the facial nerve nucleus, the nerve supply coming to that facial nerve is what forms the UMN. And this UMN involvement means the patient will have the sparing of the frowning. Okay, so the forehead will be spared here. Okay, forehead is spared, but the patient won't be able to frown in case of LMN lesion. So forehead is involved. What is the reason? It is due to the bilateral representation of the upper part of facial nerve, and so the upper part of facial nerve will not be involved in case of a UMN lesion. Okay. Now, what about the Bell's phenomenon? Bell's phenomenon also won't be seen in UMN lesion, because here also it is the orbicularis oculi which is helping with the eye closure that is getting lost, and that will be lost only in LMN lesion. In UMN lesion it won't be lost. So Bell's phenomenon will be negative here, whereas it will be positive. Now what about taste sensation? Okay, taste sensation will be gone in LMN lesion. Hyperacusis will be present in LMN lesion. All these won't be present in case of UMN lesion. Okay, and hemiplegia will be present in upper motor neuron lesion, whereas in LMN lesion there won't be hemiplegia. Now site of lesion will be anywhere before the upper motor, anywhere before the lower motor neuron, that is in the pontomedullary junction. So up to pontomedullary junction it can be, whereas LMN lesion starts from the pontomedullary junction and up to the neuromuscular junction, anywhere it could be. And muscle atrophy is a feature of LMN lesion. Here there is no muscle atrophy present. Okay, so this is how you differentiate between an UMN and LMN lesion, but the most important thing is to look for the forehead sparing. Okay, so that's about the anatomy of facial nerve in detail. So what have we learned today? We have learned first of all that facial nerve has got two parts, the sensory part and the motor part, and hence it is a mixed nerve, and this facial nerve is actually having three parts. That is, the facial nerve has got an intracranial part, an intratemporal part and an extracranial part, and the intracranial part is about 16 to 18 millimeter in length, and the intratemporal part is further divided into 4. And what are they? They are the meatal segment, labyrinthine segment, the tympanic segment and the mastoid segment. And the extracranial part is a part which exits from the stylomastoid foramen. It further divides into temporofacial and cervicofacial, and this temporofacial further divides as the temporal branch, zygomatic branch. Okay, and the other one divides into buccal, marginal mandibular and cervical. Okay, so this is how the facial nerve is divided. Now what are the branches of the facial nerve? The branches of facial nerve include, the first branch is the greater petrosal nerve, and then what else you have? You have the nerve twistor PDS, and then you have the coda tympani nerve. But before coda tympani nerve arises, you have the communicating branch to vagus, which helps in the sensory supply of the pinna, retroauricular groove, external aortic canal, etc. Then you have the posterior auricular branch before it goes into branching, as well as the branch nerve to stylohyoid as well as posterior belly of digastric. Okay, all these branches are there for facial nerve, and we learned about the various topodiagnostic tests which helps in assessing where the lesion has occurred. And what else did we learn today? We learned about the blood supply of facial nerve. Okay, so we now know in detail about the anatomy of facial nerve. We also know how to avoid injury while doing a tympanomastoid surgery as well as a parotid surgery by looking for various landmarks of the facial nerve. Okay, so these are the things we learned today. The next session we will be learning about the various disorders associated with facial nerve, their treatment, and how to assess their prognosis using certain tests. All these things will be learned in the subsequent session. For now, goodbye.